Hi, everyone. So I am here today to provide you all with some updates regarding my case study, and also answer some of the questions that you guys have left for me and give you more clarification on what's been going on with the case. So just to kind of quickly review on what my case study was for some of you that might have forgot, or just to kind of get you back up to speed, my case study was about a 26-month-old child who was misdiagnosed with having normal hearing from an initial diagnostic ABR after she was born in 2021, and kind of figured out what led to the findings of her significant hearing loss. To quickly review, the patient still does not have any intelligible speech. So she was recently seen for a sedated ABR at Kaiser Oakland's pediatric OR unit in September of this year. Her results were a severe sensory neural hearing loss in that right ear, and then the profound sensory neural hearing loss in the left ear. We used ASSR to evaluate her estimated thresholds in both ears, and those results were consistent with what we found from that diagnostic ABR. Just to quickly review also, per HIPAA regulations, the patient is de-identified for this case study as well. So one of the questions that you guys have left for me was, in terms of misdiagnosis, is there a chance that other patients have been misdiagnosed if an ABR was conducted in a similar manner? So I guess I'm going to be able to answer this kind of more in a general perspective. I would say yes. So generally, you could be more prone to having a misdiagnosis if you were to conduct the ABR in the similar manner that the initial provider conducted the ABR. And the reason why I would say this was kind of learning about this case and my preceptor's point of views regarding that first ABR was the biggest takeaway from that initial ABR is if you are really trying hard to find a wave 5, then more than likely it's not there, right? Because wave 5 should be very clear from the minute that it starts to stimulate, right? The minute that you start playing the clicks or the tone bursts and you start to see the morphology kind of start to form, if it's not there and you're trying really hard, more than likely it's flat. It's not repeatable. It's absent, wave 5. There's no sense in trying to really manipulate the y-axis to try to find it. And as for the provider, to give you guys an update in general, the provider who conducted that initial ABR, it was her first and only ABR test that she performed at Kaiser Santa Rosa, and the provider no longer works for Kaiser. So that was her first and only ABR. And so if you're not knowledgeable in the testing of an ABR, it might be really hard for you to be confident in the results, right? So if you are conducting an ABR, it's really important to be confident in what you're doing and what exactly it is that you're looking for. So to answer this question, yeah, it can be easy to misdiagnose if you're not knowing what you're doing. To kind of follow up here, question number 2. Is there any other symptoms other than the hearing loss and facial features that led you to charge? So I know that we mentioned that some of the providers were thinking that this patient had charge syndrome, and there wasn't really any other symptoms or any red flags that the patient had other than that facial feature and the hearing loss. My preceptor said that the biggest red flag for her charge, for possibly having charge, was that the patient had kind of more of a square face that is more traditional to charge syndrome, and also those arched eyebrows that really have how would we say, a significant angle, a big arc, and with that more big prominent forehead. So it kind of looked very similar to charge, but kind of looking over all of the history and the data, we weren't really suspecting it anymore. But no, to answer the question, there wasn't really anything else that gave us a red flag other than the facial features. And then this question, this one was a tough one. So what do you think were the most challenging aspects in terms of counseling the patient's parents on the new diagnosis? So the hardest part, this can go for any situation, right? A patient that has hearing loss and the family is now hearing about this for the very first time. The way that I'm kind of looking at this question is I can relate to it, right? Because my nephew has profound sensory neural hearing loss, and he's the very first member of my family to ever have a hearing loss that required a CI, and just kind of that shock, right? So I kind of empathize with the patients and their family, because the hardest part was really not giving them the number one reason why this patient had hearing loss, right? We don't know why their child has a hearing loss of this nature and how severe it was. And when we told the parents that basically that their child was essentially deaf in one ear and had a very severe hearing loss on the other side, it was a big wake up call for the parents, right? Parents always want to know what's wrong with their child. And the fact that we really couldn't find the number one cause other than that it was an idiopathic hearing loss was really difficult for for the parents to accept. The parents were both crying and, in shock and just in denial. And my preceptor really did her best with comforting them and letting them know, like, hey, this was not your fault. This is just something that can occur. It's not common, but again, it's something that we just have to now figure out and attack and come up with a plan to help your child. My preceptor just kept confirming their suspicions on why their child was so delayed in their speech, right? So the parents were saying, like, it all makes sense because whenever I would call my daughter's name, she would never turn unless if I was really looking at her and trying to get her attention. We were playing loud music and she would never react to it. So there were a lot of concerns and red flags that the parents have. I guess they were just not ready to really believe that they were correct in their suspicions. But nonetheless, I think that's the biggest challenge, was kind of telling them that their child was deaf. And I remember when my sister first heard the news, she was in a really dark place initially, right? Just kind of learning, like, oh my God, my firstborn child is deaf. What did I do? How could this have happened? And I saw that same emotion in the mother that of the patient. And I was like, I'm so sorry, man. Like, that was a really hard, difficult situation to be in. But now, nonetheless, we do have that plan in place. And I do have some updates for you guys that I want to share with you. So here are some of the current updates that I have found out about this specific case. So the little girl, she is still utilizing her loaner hearing aid from Kaiser Santa Rosa. It's a Phonak Sky BTE. And good news. So since she is a CI candidate, she actually has her surgery scheduled for a bilateral implantation with one of our surgeons, Dr. Schlegel. That's scheduled for this upcoming December. A big fun fact, Dr. Schlegel is actually the surgeon that did my nephew's cochlear implants. So I'm very confident that she's in good hands with Dr. Schlegel. He's a really great surgeon. He remembers my nephew very well. He did his surgery. He did the revision surgery for one of his ears. He's very knowledgeable. So I know that this family's in good hands with Dr. Schlegel. The family also ended up choosing Cochlear as their manufacturer for the CIs. And I think the reason why they chose it was because the CI audiologist, that one of my preceptors, she used to work for Cochlear. She was one of the Cochlear reps, and she's very knowledgeable with Cochlear. And the family really wanted to make sure that they had an audiologist that knew what they were doing with CI. They weren't really wanting to go the AB or Medell route. They did do their research, but ultimately what won them over was the fact that the audiologist who was going to take over is a Cochlear or previous Cochlear employee. So the next thing here, I know I mentioned that they're sent in a referral for genetic testing. They actually got the genetic testing done. We're still waiting for those results. So that's going to take a few more weeks into process, but it's already in the lab. It's getting sent out already. Now that we've kind of ruled out that charge syndrome, my preceptor and the Dr. Schlegel and some of the other providers, even the pediatrician, they're also now suspecting that it's just one of the Connexin 26 genetic mutations. She doesn't have a family history. There's no congenital history of hearing loss. Really unknown reason why, the patient has this hearing loss. And now the providers are really suspecting that it might be just Connexin 26. Good news is the MRI of the internal auditory canals were normal, unremarkable. Initially, they were expecting maybe the ossicles to be a little bit deformed or abnormal or show some type of malformation, but overall, all of the structures were really healthy. Everything looked great. Here is the detailed information about what they found from the MRI. So the MRI is back in November of 2023. Overall, there was no mass, no tumors. The seventh and eighth cranial nerves are all normal. The cochlea, the semicircular canals are all normal with good morphology. The brainstem and cerebellum are normal. No hemorrhages, no mass or herniations in the brain. Overall, no hydrocephalus, all the extra axial abnormalities. So, nonetheless, this MRI was pretty much normal, and they gave us this pretty much gave us the green light to get that surgery scheduled. I'm very impressed with the fact that this case is they're getting the ball rolling really fast. Sometimes, the ENT surgeons, if we're doing a cochlear implant evaluation or a consultation in, let's say, now in November, their surgeons openings for a surgery is not until usually like March. They're a couple months booked. They're booked out a couple of months. So the fact that Dr. Schlegel, for example, was able to get them in pretty fast was very impressive to me, to be honest. So now I'm really excited to see how she does on activation day and just kind of moving forward and seeing how things go with this specific patient. But yeah, overall for now, those are the two or biggest updates that I have for all of you. I will definitely follow up more and kind of figure out what's been going on as the time goes on. But yeah, I suspect that she's going to be a really great CI candidate, and she's really going to flourish with her new CIs, and go from there. Thank you guys for listening, and have a good one. Bye-bye.